Sir, we'll start, huh?
Okay. Thank you.
So we are on live, sir. We are good to go now.
Okay, thank you. Hello, doctors. Good evening and welcome to this program on experience sharing program on managing PPH, case studies from labor room. Today we have got honorable speaker Dr. Kanchan Kanjilal with us to share his experience. This program is brought to you by Hetero Healthcare, an innovative pharmaceutical company. For Hetero Healthcare has 25 years of excellence and 36 state-of-art manufacturing facilities, 300 plus products in portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, API and FDFs in the world and has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients, because of which in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's program, Experience Sharing Program on Managing PPH, as I said, we have got Honorable Speaker Dr. Kanchan Kanjilal with us. Welcome, sir. Welcome to this program. Dr. Kanchan Kanjilal, sir, is MBBS from Calcutta University 1986 batch, MD in Obstetrics and Gynecology from Sambalpur University 1992, MRCOG from Royal College of Obstetrics and Gynecology London 1997, DFFP from Royal College of Obstetrics and Gynecology London 1999, USG training in Obstetrics and Gynecology started in the NW Hospital, Mumbai in 1990. USG practice continued in all hospitals during MD and MRCOG courses in Sambalpur, India and United Kingdom for 3 and 7 years respectively. Sir is presently practicing as a leading consultant in obstetrics and gynecology over in Calcutta over last 1.5 decade. Sir is a consultant at Swapnadeep Clinic. With this brief introduction, I hand over the session to Dr. Kanchan Kanjilal. Over to you, sir. I stop sharing.
Thank you. Thank you, Dr. Prashant, for the nice introduction. We will discuss today in this evening about postpartum hemorrhage. It's fantastic management, the recent management with Carbetocin molecule. Before I go ahead about Carbetocin molecule, I must say something about postpartum hemorrhage. For all obstetricians, postpartum hemorrhage is a nightmare if it is really a severe postpartum hemorrhage. But in practice, in day-to-day practice, we always come across with these particular complications in minor amount, but major amount causing disability, even death, if it is not managed properly. And in this management, Carbetocin molecule is a new innovation, and it is a very effective and very strong molecule to control this postpartum hemorrhage happening, rather not control, is happening. This is preventative medication, and this is something which is very effective, and if it is properly used, we always give a best shot in our hand for the patient. So what is postpartum hemorrhage? If you look at the diagram, it's not sharing. I don't know why. It's not moving.
Sir, you want me to share the slides?
Well, it is not moving. I don't know why.
Then, sir, I will start sharing. You can ask me to move on.
Okay, fine.
Yeah.
Overview of the postpartum hemorrhage. Move on.
Yeah, I will start sharing, sir.
Please. Okay. So next slide, please.
Yes, sir.
Looking at the mechanism of blood loss and its prevention, what happens physiologically is it is about the next slide. So next slide, please. All the muscles which are present in the uterus, they have got this important function of stopping this blood loss in the form of postpartum hemorrhage. These muscle fibers grows along as well as crisscross manner, and they once they start really contracting, and they have got a unique property of retraction also. This contraction and retraction together produces this important phenomena of blood, obstructing the blood vessels. This is not moving, Dr. Prashant. This slide is not moving. I don't know why. I cannot see this is moving.
Sir, you tell me next. I will start moving.
Okay. So overview of postpartum hemorrhage. So
Should I move ahead?
this particular mechanism of the blood vessels being blocked by the contracting and the retracting muscles is an important mechanism. And this mechanism is actually maintained by the tone of the muscles of the uterus after the delivery is over. After the baby is delivered and after birth, that means placenta and membrane and fluid all are drained out and evacuated from the uterus. This mechanism of having nice tone is an important mechanism for the most important mechanism for this arresting of the postpartum hemorrhage and preventing it happening. The next important is obviously Dr. Prashant is not moving. Overview of the postpartum hemorrhage, it is stuck over there.
Sir, you tell me, you want to go ahead or say you want to be on this slide?
Well, no, I said that we should move around.
This one?
The next slide, please.
This one?
I cannot see any slide over here. I don't know why.
I'm sharing the slide actually.
All right. Okay. Now I can see now.
You can see
Right.
now?
Yeah.
Please
So
tell me next, sir. I will move on.
No, if you go from the very beginning, because I was not able to see the previous slides. Yeah, this one. Right. This is the mechanism we are talking about. So maintaining uterine tone helps us to prevent this postpartum hemorrhage happening. So tone is the most important issue. In normal postpartum patients, what happened, this tone is maintained and there is no happening of the PPH. But when there is PPH happening, that means that tone is failing and the PPH is very much common happening in this situation. So if the patient is at risk, the woman is at risk of PPH, that means over distension of the uterus for any reason, or the clotting mechanism not working, or by these reasons, this PPH is happening. So this is important to understand that the tonicity of the uterus muscle is very important mechanism to prevent this PPH happening. The other factors are important, but they are the less important as compared to the tone factor. So if you come to the four T things, that means the tone which I have outlined, the thrombin formation, this is the basic of the clotting mechanism, and on all the bleeding in our system, in our body, ultimately gets controlled with the help of this thrombin formation. If the coagulopathies are around, that means the thrombin formation is not adequate or not happening right way, then the bleeding comes in the picture. So thrombin is the formation is the most important thing which happens in the microscopic level inside the blood vessels at the site of the trauma. So that is important, and obviously thrombin is the next important one. Now, if there is trauma, that means when you cut the uterus, or when the uterus is torn, or the parametrium is torn, or the vagina is torn for some reason or other, then these mechanisms of having adequate tone, having adequate thrombin formation may not happen, and thereby any trauma which happens in the which as the etiology of the postpartum hemorrhage, that is to be taken care of quickly, and then the bleeding get arrested, and obviously PPH, we can come out from the PPH. And the last but not the least is the presence of tissue left behind inside the uterine cavity or in the genital canal. That means these tissues remaining inside the uterine cavity, that they help, they hinders in the formation of the adequate tone, and obviously bleeding continues and the PPH becomes a problem for us. The next slide, please. So what you find in PPH is obviously some signs and some symptoms. Visibly, you can see that the bleeding is happening. It is not getting arrested. If you palpate the uterus, you get the loss of tone, the bogginess, feeling of the bogginess of the uterus, and because of this increasing bleeding inside the uterus and outside, the girth of the abdomen increases, and obviously these all actually gets on, and thereby the PPH gets mild, moderate, and severe. And if not arrested properly, if not managed properly, then the life of the mother may be in danger. So if you go by the classification, you find that mild PPH or before mild PPH, minimum PPH occurs, which is about 10 to 15% of the blood loss. The compensatory mechanisms comes in picture, and obviously that can arrest the things adequately. When the bleeding is a bit more, that means 15 to 25%, 1 liter to 1.5 liter, obviously more and more symptoms comes in sight, and obviously you get fall in blood pressure, change in systolic pressure comes, which falls down to 80 to 100, and obviously the other symptoms increases. That weak patient complains of weakness, and the sweating occurs, and the tachycardia occurs. This is part of the compensatory mechanism which comes in the system. The more the blood loss, that means if it is moderate, then 25 to 35% of the blood is being lost. Then obviously the blood pressure falls more, which is 70 to 80 millimeter of systolic blood pressure. And obviously patient symptoms becomes more restlessness, pallor, and oliguria even sets in, because kidney is not getting enough blood supply, and obviously blood and the urine formation is suffering. And if it is severe, then more blood loss, that means 35 to 45% of blood loss, and that there is profound fall of the blood pressure to 50 to 70 millimeter of mercury, and the patient may even collapse and produces symptoms like air hunger and even anuria. So we should not allow this to happen, to go to that stage. We should always try to prevent it, and if it happens, quickly manage it so that the severity of is not increased, and obviously patient is saved in that situation. Next slide, please. So what you do, you take care of all these T's. That means poor uterine tone, you correct them. Poor there is tear or trauma in the genital tract, you repair them. There is hemoglobinopathies, which are clotting factor problem, which is known ahead. Then you take adequate preventive measures to coagulopathies not to take over. That means you give proper amount of replacement with the help of fresh blood or red blood cell, or of cryopreservatives, and obviously these are phase frozen plasma and cryo things, and this is important to make sure that you have taken adequate care and preventative measures has been in place. And obviously if there is suggestion of retained tissue, you have to remove them quickly so that they are controlled, and obviously tone comes back, and the PPH is sorted. All the sign symptoms and the management protocol, we day to day in practice we get them, and all these are outlined in this slide very shortly and very adeptly. The attempt should be made to identify the cause, in real cause, which is the woman having at this present moment, and the bleeding can be quickly controlled with the help of the correction of the factors which are playing to have this PPH occurring in this present situation. Next slide, please. So why you try to prevent it? Because any situation, any disease process, if you can prevent it, that gives you the best outcome. Resource wise, you use less resource, and obviously you get the best outcome possible. That's why the adage is there, the proverb is there, prevention is always better than cure. So your attempt should be, our attempt is always to prevent the PPH happening. And in that armamentarium, to prevent the PPH happening, carbetocin is a very important molecule. Previously, carbetocin, when it came, it was first described in 1974, and it was in use first time, I think, is in UK and Canada in 1997 also. But presently, it is still not used in states and And in Japan, I don't know why, but that is the situation. That is the practical situation about there. So initially, when carbetocin came in the market, and carbetocin is important, it is also in the essential drug list of the WHO. So carbetocin is important because it is a better molecule. It's better over what? Better over our traditional oxytocin, which is being widely used around the world is used. It is also very effective. But carbetocin has got some advantages, which is important to extract, because you don't need to give it repeated doses. You give just one dose, and the molecule starts working, and it stays for a long time. Initial carbetocin, when it came in market, it was not heat stable, but now the present form is basically heat stable, and it is available in room temperature, and that is very important in resource poor states, situation in countries and states where maintenance of refrigeration is an important issue, and in peripheral field sometimes that is not really practically possible. So in this situation, carbetocin has got a fantastic edge over oxytocin. Price may be a bit more, but that price can be is not exorbitant. If you compare one ampoule of Syntocin on 5 units, it probably is 25 rupees. And if you pay about 250 rupees, which is about 10 times for one ampoule of carbetocin. So this gap is not very much unless you are using, unless it is being used, it is being used in effective way, then that amount of price can be obviously we can take off. But oxytocin, if you compare with oxytocin, and and ergot alkaloids should be kept in the refrigerator to avoid degradation, as compared to present formulation of the carbetocin, which is very much stable at room temperature. His stable form of oxytocin is currently not available, but it is obviously available with carbetocin. Carbetocin has got a shelf life of 24 months at 30 degrees centigrade and 75% humidity, which is reasonable. That means 30 degrees centigrade, maintenance of 30 degrees centigrade. Previous formulation of carbetocin was not heat stable, that was stored like oxytocin to 2 to 8 degrees centigrade. So cold chain maintenance is not needed for present heat stable formulation of the carbetocin. Resource poor countries do not always have cold chain transport and storage capabilities, and obviously that is an issue for them. But for carbetocin, this is not a problem. So it is supplied in the form of in a vial, 100 microgram dose in a vial, and that has to be given as shot, intravenous or intramuscular. It can be used in both ways. Next slide, please. So, as we have said that there were molecules before carbetocin like oxytocin, ergometrin, symptometrin, which is a combination, and obviously misoprostol. So these are the molecules other than carbetocin which are also used in practice, and they are all effective in their own way. But carbetocin is number one, I think, in the form of prevention of PPH practice. So if you are talking about prevention, then carbetocin gives you the best shot, but it is not good for treatment. So for treatment, the age-old oxytocin, the ergometrin, and the symptometrin are to be used as and when necessary, as well as misoprostol. The one point we must also know that carbetocin should not be repeatedly used. That means you have given the first dose and you try to give the second dose, because that is not practical. And giving oxytocin after carbetocin is not an indication, because they work through the same receptors. So giving carbetocin as single dose is okay, but oxytocin is not to be used after carbetocin. You can always use misoprostol or prostaglandin after carbetocin, because that gives a synergistic effect to some extent, but not oxytocin. So time of administration, it can be used, uterotonic agents can be used at the crowning of the baby's head, at the vaginal delivery situation, at the delivery of the anterior shoulder, and at the end of the stage of the labor, at the end of the second stage of the labor, following the delivery of the placenta also. So these are the times of use of these molecules. Prophylactic use is for prevention of the PPH and active management of the third stage of labor. And prophylactic use for carbetocin is most effective, and that is the only indicated use of the carbetocin. And therapeutic use of uterotonic agents is there for management of PPH. Once it has happened, then you can use uterotonic agents also. You should be using the uterotonic agents to minimize PPH and control the PPH as quickly as possible. Molecules other than carbetocin, like oxytocin, ergometrin, and cytometrin, misoprostol, and prostaglandin. Next slide, please. So why carbetocin is so much of effective as compared to oxytocin? There are three structural changes which has occurred in the molecule of the oxytocin to make carbetocin. And these structural changes are really the reason for this increased effectiveness of the carbetocin molecule. It is basically modified oxytocin. It's a long-acting oxytocin form. This is carbetocin. So once you apply it, the half-life is more, the elimination time is more, the working hours of this is more, depending obviously of the route of use, IM, intravascular, and intravenous and intramuscular. Intramuscular obviously starts a bit late, but persists perhaps a bit longer. And IV starts almost immediately, whereas that terminates the effects a bit quicker than intramuscular situation. So these changes, these three changes which are depicted in the molecule of oxytocin, these changes has occurred to make the carbetocin, and carbetocin gives us prolonged half-life in reducing the enzymatic degradation. So it is synthetic, it is long-acting, it is analog, it is basically a long-acting analog of the oxytocin. The prevention of PPH therapeutic indication, that is the only use to minimize the uterine for carbetocin, but it is very effective, very strong use. One vial contains 100 microgram, as I said, as a 1 ml solution for injection. Next slide, please. So what are the clinical evidences which we have got over here? So if you compare the characteristics, that oxytocin as compared to heat stable carbetocin, this is a synthetic molecule over oxytocin. This is also synthetic, the oxytocin, but it is a peptide form. It is it is occurring naturally in the posterior pituitary of our brain, and this is obviously it is naturally present and naturally available in our system. But when we apply from exterior, this is synthetic preparation. Long-acting synthetic analog of the oxytocin is agonistic activity is the carbetocin. It binds to the same receptors, the oxytocin receptors in the uterine smooth muscles, resulting in rhythmic contraction. That is important, and rhythmic contraction persists for longer time. Initial tonic contraction starts and that persists short time, and then the rhythmic contraction continues, and it may continue up to 120 minutes. So this results in increased uterine tone and persistent uterine tone. With oxytocin also you can get persistent uterine tone, but you have to give it oxytocin infusion in a drip, so that the degrading molecules are quickly replaced with the continuing drip. And for carbetocin, that is not the issue. You just give a single dose IM or IV. So that is the pharmacokinetics. Intravenous use, almost immediate action with oxytocin, which peaks to about 30 minutes time. And for carbetocin, the sustained uterine contractions within 2 minutes with IV preparation lasting for about 6 minutes, and followed by rhythmic contractions which persist about 60 minutes. That is a good timing. And if you give intramuscular, the oxytocin will be taking 3 to 7 minutes to start working and produces a longer lasting clinical effect up to 60 minutes. This is with any medicine. If you give intramuscular, that persists for longer time. Starts a bit later, but persists for longer time. Half-life is 1 to 6 minutes, but if you come to carbetocin, the half-life will be increased to 40 minutes. Storage condition, we have already told, we have already discussed. So oxidation use can be used in induction of labor, augmentation of labor, prevention of PPH, and treatment of PPH. But in contrast, carbetocin is only used for prevention of PPH. That is the single most important use and very effective use of carbetocin, and a very selective use. Next slide, please. So these clinical facts has been corroborated with the trials. If you go for this champion trial, you see a lot of patients has been recruited here. It's a multi-centric trial. This has shown that this molecule is not inferior to oxytocin. This study design is non-inferiorly double-blinded randomized trial. The objective is to compare the effectiveness of these two molecules in the prevention of PPH after vaginal birth. Patients collected 30,000 yearly across 10 countries, obviously including India. Primary outcomes, the proportion of the women with blood loss of at least 500 ml or use of additional uterotonic agents, and the proportion of the women with blood loss of at least 1,000 ml. Next slide, please. You see the parameters, carbetocin and oxytocin are comparable. All the statistics are showing comparable results. So that's why the outcome of the champion trial is that both the molecules are comparable. The safety-wise associated episodes of unexpected episodes happening is again comparable, 4.9% and 4.7% in the two molecules. And serious episode adverse effects is 0.7% versus 0.6%. The conclusion was the carbetocin was non-inferior to oxytocin for the prevention of the blood loss of at least 500 ml or the use of the additional uterotonic agents. So these two molecules are comparable, but in practical setup, carbetocin has got edge over oxytocin. If you are not bothered about the price. So next slide, please. We are talking about vaginal delivery in the champion study. Now this good effect has been extended in cesarean section delivery also. And the Cochrane data says that for women which undergone a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonic compared to oxytocin. Also, carbetocin is associated with less blood loss compared to centometrin in the prevention of BPH for women who have vaginal deliveries, and is associated with significantly fewer adverse effects. So either abdominal route or vaginal route, if you compare, you are getting either almost comparable or better outcome with carbetocin. Next slide, please. So guideline recommendation, this is an important slide. You see all the worlds around the world, it is being accepted and recommended. All the bodies are recommending this. WHO from 2018, they are recommending carbetocin. Canada, they're using it for a long time, 1997. From 1997, they're using. New Zealand, they are also recommending, their body is also recommending this thing, this molecule. FIGO, Federation of International Gynecology and Obstetrics, they are recommending. Germany, Austria, Swiss body, France, all are recommending. So that is an important fact that this is being recommended all over the world. Russian Federation is also using from 2013. Chinese Society, they are also using from 2014. Philippines, Queensland Maternity, uh, expert group of the Polish Gynecological Society, Danish Society, they are all using. Mexican Society, they are all using it. So this has got a wide acceptance around the world. Next slide, please. So as we talked about all these pharmacokinetics, use, storage, benefits, we always were mentioning that for prevention aspect, carbetocin is the better molecule. Um, if money, the difference of money is not much, but if that is acceptable, you better use carbetocin. And in our clinical practice, those who use the carbetocin molecule, they will all agree with that fact that this is obviously a better choice. The price difference is there, and if you're talking about planning, if you're talking about mass use, then the difference will be obviously of an issue. And obviously those bodies who are sanctioning the money, they will be deciding about whether it is to be used on a mass scale. But most of the bodies who have used it, who are recommending it around the world, they are always saying that this is a smarter, this is superior and safer choice. The benefit which is available at our disposal is there with these outcomes, but obviously that comes with a little bit extra cost. And I believe that giving extra cost, getting a better outcome is always acceptable if and preferable choice. And in our practice also, we follow the same formula. When there is resource is a problem, when there is finance is a problem, and obviously we bank on syntocin on a larger way. But whenever it is possible, which is possible, I think more than 80% cases, we use carbetocin molecule, because as I said, the price difference is not much. 25 rupees, around 25 rupees for single 5 units syntocinon, as compared to one ampoule of carbetocin, which is about 250 to 350. So, and also you have to remember that you are using multiple doses of syntocinon. So the price of 25 into, say you're using 5 units, that comes to 125, or 10 units, that comes to 250. So 10 ampoules, not 10 units. 10 ampoules of 5 units, that is 50 units. That high amount is used very rarely, but probably mostly in the treatment side. But preventative side is 10 to 20 units of syntocinon in our practice. We use during delivery that amount, and for continuation of the good effect for about 6 hours to continue, say another 10 to 20 or 15 units of syntocin is enough. If it is 15 units, then comes 3 ampoule, and during the delivery time you are using perhaps 1 or 2 ampoule. So 5 ampoule is giving you 125 price wise, as compared to 1 ampoule of carbetocin, which gives about 250 to 350. So price difference when multiple doses are being used with the syntocinon, that also comes down. So that is important, that is to be remembered. And as I said, we always use this molecule to the great advantage of the patient to minimize PPH happening. And when something happens, we use the other molecule also in an addition to carbetocin. But that occasion, as I said, in our observation is very minimum. If you use it properly, and obviously the anesthetic colleague is a good hand in your good use of the carbetocin, because they inject that thing while you deliver the baby, and obviously they synchronize with you, giving you the best effect. And the good anesthetist, and knowing that molecules use better, is an additional boon for you. So that is what is very important. And carbetocin, day by day, I think the acceptance is increasing. And in my practice, as I mentioned, carbetocin is an important armamentarium, and I always try to use it whenever there is no contraindication and no financial barrier. Talking about contraindication, you should not be using carbetocin in situations like epilepsy, in situations like multiple use of carbetocin, or when there is other contraindication or allergic conditions known for carbetocin. So these are to be remembered. Epilepsy and all these things, there is contraindication for carbetocin. So this much is I must be mentioning to you. So this is a good molecule in my choice, and I think Dr. Prashant will be perhaps adding a few words about carbetocin.
Sir, thank you so much, sir, for sharing your experience. Since how long, sir, you have been using this drug?
I think I'm using about 2 years now.
Wonderful.
In Kolkata, I think it is available from the
Yes.
very beginning. I'm using in
Yes.
selective situations, but day by day, more and more indications are being included in the use of it.
So you use it in all patients or selectively in high
That's
risk
why I
patients?
said in selective patient, when finance
Selective.
is not a problem and
Correct.
when there is no
Correct.
contraindication,
Correct.
I use it. Perhaps
sir,
70% cases I use it.
Correct. Understand. And you, which route do you generally use, IV or IM?
Intravenous.
Intravenous.
Because the anesthetic is around and you're giving the intravenous single dose.
Yes.
That is the best effective because it starts working immediately.
Absolutely.
And it persists for 60 minutes at least. So that is a good
Absolutely.
time frame you are getting. The window time is fantastic.
Correct. And sir, these uterotonics, suppose if carbetocin, even if someone gets a PPH after carbetocin, is the amount of blood lost less?
I think if you are using it properly, then the chance of it happening is not there. But in practice, sometimes desynchronization can happen.
Yes,
and in those situations, obviously, as you said, the observation-wise, the blood loss is less. And also, you can use the other molecules like prostaglandin and misoprostol along with it to minimize whatever is happening.
Correct.
Yeah.
Sir, thank you so much, sir, for sharing your experience. I mean, you have covered a very comprehensively carbetocin. And I'm sure the doctors have benefited out of your sharing your experience.
Thank you, Team Hetero and Frenja Group, and also the IT group behind, and also obviously Dr. Prashant, who has conducted the things very fantastically. Thank you.
Thank you, sir. Thanks all the doctors. Thanks IT team. Thanks sales and marketing of Hetero. Thank you.
The team.
Thanks so much, sir.
Thank
you can log off, sir. Thank you.
Sure. Thank you. Bye.
Bhuvan, thank you very much. You can log off.
Thank you, sir. Bye, sir.
Bye.